Hello, friends. I'll be taking through a bouquet of six interesting cases. So, I was meant to give on this topic challenging scenarios in ICU. So, in Tirchi on 31st August. So, I picked up around six cases which we saw in our ICU just in last 6 months. So, these cases I believe are interesting to me. So, I'm not sure whether this would incite same interest in all of you. So I'll just take you through cases which I felt were challenging in its own way as to how we approach these. So the first case would be of this particular case, 25-year-old male with severe polytrauma with severe ARDS. So how do we deal with this? I'd covered on this in another talk, so I'll just give you the salient aspects as to whether there is a role of ECMO in such situations with polytrauma with severe ARDS with traumatic brain injury. So the case two is we had a patient with brain death, and our night team were interviewed with certain aspects in establishing the diagnosis. We had done the first test, so obviously the night team had certain issues which they raised. So diagnostic dilemma. So I thought that would be interesting as well for all our intensive care fraternity. So the third case is a blue lady, so a patient who came fully blue, cyanosed. So that was an interesting sort of a poisoning case that I thought we can discuss. So case four is of an interesting toxic epidermolysis necrosis. The point in contention is the role of steroids and IVIG, and to have some semblance on clarity on this. And the case five is infective endocarditis. Would someone embark on surgical procedure in an acute phase? So that would be the question. So we'll try to address because these are all life-saving measures for these clinical situations. And case six is how important it is for us to desperately scout for the source in septic shock. So these are the six cases that I'll take you through. So the first scenario case challenge that we had was a 25-year-old male who came to our ICU 16 hours after he sustained polytrauma. As you see, he had traumatic brain injury with subarachnoid hemorrhage with a GCS of E1, M2, V1, multiple wrist fractures, bilateral hemothorax, a lot of trauma. So basically, he had fell down the bike and tractor had run on him, left pneumothorax, hemoperitoneum, along with grade 3 liver injury, grade 2 splenic injury, and he had bled a lot, and he had a hemoperitoneum and with adrenal hematoma, and he had even the long bone fractures, humerus fractures, and scapular fracture. So when he came 16 hours later, he was intubated, he was gasping on the ventilator, he had left underwater seal drain. And as you see the chest, he had ARDS, he had a lot of contusions on the lungs. So when he came, he had a type 2 respiratory failure with CO2 of 130, and he was literally gasping. Obviously, for 6 hours, we tried all the arts net maneuvers, but nothing would work in this sort of a disastrous sort of a clinical situation. This patient was initiated on ECMO. So obviously, when he was initiated on VV ECMO, so the intent was to bring down the CO2 slowly, and CO2s did come down slowly from 118 to 53.9 by calibrating the flow and the sweep gas and so on and so forth, flow rates and sweep gas, because we had to keep the flow rates at a higher rate to avoid anticoagulation because of the bleeding issues. So 12 days he was on VV ECMO. So we had a lot of challenges and issues because 2 days, 48 hours, the ECMO was run without anticoagulation, keeping the flow rates at a higher sort of a rate. And even after that, a slow anticoagulation was initiated, calibrating to the ACT levels. Despite that, he had a lot of bleeding from the underwater seal drain, which was all addressed. He did develop AKI. He was initiated on RRT. And the bleeding issues didn't stop there. He had multiple lung collapses with blood clots and bleeding from the tracheostomy. All these were addressed, and patient did get better. So the question that we intend to answer is in patients with severe traumatic brain injury with ARDS, what are the solutions or evidence-based solutions that we can have? So obviously, when you see someone who's come with a very high CO2 of 120, when you use low tidal volume, so I would expect CO2s to go up and oxygen also. We tolerate relative hypoxemia to 88. But is this acceptable in traumatic brain injury? So the answer is the targets of CO2 and oxygen should be targeted to ensure that ICPs are kept low and adequate brain tissue oxygenation happens. The ideal targets, as per the evidence, is Now, before we used to accept the concept of permissive hypercapnia. So right now we are sort of shunning and downpedaling on the concept of severe hypercapnia, like you see in this patient. The targets when there is a concomitant traumatic brain injury, CO2 has to be maintained between 35 to 45. Not, we cannot allow permissive hypercapnia in ARDS. And PaO2, the relative hypoxemia which we tolerate in ARDS is unacceptable when there is a concomitant traumatic brain injury, because the studies have shown that PaO2 of less than 110 in patients with traumatic brain injury leads to odds of higher mortality. So that is something that we need to bear in. So we have to maintain high PaO2 when there is a concomitant TBI, and that's why ECMO was the solution in this patient. And how about PEEP? Because there is a notion that high PEEP is dangerous for traumatic brain injury, but studies have shown up to 12 centimeters of water we can maintain the PEEP, because up to 12 centimeters does not cause any significant change in the ICP. And what about fluids? So too much fluid is also bad in when there is a concomitant traumatic brain injury with ARDS. Too less also is bad because it can lead to worsening sort of a cerebral circulation. So euvolemia is just about what is needed to maintain adequate cerebral perfusion pressure and brain tissue oxygen. Most importantly, resuscitation should be calibrated to avoid hypotension in trauma, because hypotension is bad, and we all know, all the listeners would know that in traumatic brain injury with ARDS or without ARDS, the thing we believe is, or we follow is seven normos. So normovolemia, normoxia, normocapnia, normothermia, normotension, and normosmolality. So those are the ones we need to keep as a sacrosanct. And of course, in CPP, we have to maintain in subarachnoid hemorrhage, we have to maintain good cerebral perfusion pressure. So these are certain norms that we need to keep in mind when you have ARDS along with TBI, that permissive hypercapnia is something that we cannot accept, and permissive hypoxemia also is something we cannot accept. PEEP up to 12 you can use, euvolemia is something you can use, and you cannot use recruitment measures because high PEEP is bad. How about steroids? Because in ARDS, we tend to use steroids because it reduces the inflammation. But steroids are shown to worsen brain edema, and steroids are shown to worsen hemorrhage and ischemia and seizure threshold. So the answer is you have to individualize the risk potential, and steroids is a problem for causing ICU-acquired weakness. So summary is you have to weigh the risk-benefit sort of a balance. If ARDS is severe, like in our patient, we did use steroids. So you have to balance whether you are there to protect the brain or to the lungs, and which is possibly causing more harm to the patient. So we may have to take a call on that. So one has to ascertain the risk-benefit balance to determine whether you want to use steroids. If ARDS is more of an overriding problem, maybe I would err on using steroids. If TBI is more of a problem and lung injury is less of a problem, then perhaps we can hold steroids, would be my submission on this particular aspect. How about prone positioning in traumatic brain injury with ARDS? Prone positioning does increase the ICP because it impedes the venous return in these patients. So PROSERVA trial has shown that with prone for 16 hours, there's significant mortality benefit. So proning for more than 16 hours. But with traumatic brain injury, we do not have a clear-cut evidence. But the consensus is even with traumatic brain injury with ARDS, you can prone the patient, but you have to put in a reverse sort of a Trendelenburg sort of a position to ensure that there is sort of intracranial pressure or the blood circulation to the brain is not impeded. So, and when you prone with the head end elevation, so the change in ICP and CPP were not found to be significant. So there is an alternate. So this is something which I thought was useful. There is alternate to proning where you can put weight on the chest, which simulates the proning. So by putting the weight on the chest, it was found there is change in the chest wall compliance and elastance that happens, and there is optimization of tidal volume and PEEP that happens due to the movement of the diaphragm. And there are studies. So there is a study as of now which is undergoing called alter prone trial, where we put a weight 100 grams per kg on the chest. If you want to know how much weight to put, we have to put 100 grams per kg on the chest, which simulates proning, because proning, you are putting the weight of the chest down, right? So you put a weight on the chest. So there is this trial happening in patients with traumatic brain injury with ARDS. The inclusion criteria in altroprone is patients who have ICP more than 30 millimeter or CPP less than 60 millimeter mercury were included for this trial. The results of this trial are still not out. So it will be interesting to see. So maybe this was a thought that I put forth to my colleagues. Like if patients are undergoing ECMO, and we know it is incredibly hard to prone these patients, maybe we should think of doing this, putting a weight and maybe do our own study to see if this simulates sort of a proning and improves the outcome. So this is something which ECMO pundits can look at it as an alternative for proning. So the easiest way to put the weight, because you may be wondering, where do I get weights? The simplest way is to put your IV bags, the saline bags, because you have a large saline bags which you may use for dialysis. That is something you can put because the weight is uniformly distributed. Otherwise, you can't put a 5 kg gym weight onto the chest because that would cause more harm. So at least putting a saline bags which are weighed would have a more equivocal sort of a distribution on the chest. So this is something you can think of. So ECMO. So why we used ECMO? Because there are trials giving good signals towards benefit. So seizure trial did show that in specialist ECMO centers, early ECMO in patients with ARDS had a higher survival rate and reduced 6 months disability. And the more recent EOLIA trial showed secondary endpoints of reduction in treatment failure, reduction in the need of RRT, and reduction in the need of proning when ECMO was initiated. But how about ECMO in traumatic brain injury? So the hypothesis is that it can increase ICP, it can worsen the bleeding because you are using anticoagulation, and it can worsen the brain ischemia by impeding the venous return. So these are the hypothetical theoretical arguments that ECMO can worsen the patients in patients with traumatic brain injury. And to avoid the bleed, so now the whole notion is to use uh, ECMO circuits without anticoagulations, and you can run the circuit without anticoagulation for some time by calibrating the high flow rates, by calibrating the flow rates. Even there's a talk of pumpless extracorporeal lung assist devices. So there are case reports where modified anticoagulation has been used in patients with traumatic brain injury with ARDS who are needing ECMO. And even ECMO has been initiated in patients who have undergone decompressive craniectomy also. So the message from this case is, if patient has polytrauma with traumatic brain injury, it's not an exclusion for initiating these patients on ECMO by carefully sort of tweaking and calibrating the anticoagulation usage, like how we did. Like first 48 hours, we didn't use anticoagulation. And later on, we started at a low dose and calibrated to keep the circuits running, and we saw a remarkable outcome. And this was the outcome we saw. So this was a patient who was put on ECMO, 12 days VV ECMO, who had a remarkable improvement, and we are seeing him cutting the cake. And this is after the discharge. He came to our ICU, and that is Dr. Pratibha, who put in a lot of effort to she's our ECMO specialist, so put her effort in salvaging this patient. So it's a very interesting case where don't write off, because it's a young life we could save by putting him on an ECMO. Otherwise, he would have died. He had no option. He came gasping with so much of injuries. And what really saved is a timely decision of putting him on ECMO was what saved his life. So please don't write off any case where there is a possibility of saving a valuable life by putting them on ECMO in this sort of a situation. So this is an interesting case. So this just came around 1 week or 10 days back. So this was a patient who had a cardiac arrest outside. She's a COPD with type 2 respiratory failure. While coming to the hospital in the car, she had a cardiac arrest. And when she came, she was intubated, ventilated, resuscitated, and she lost all her brainstem reflexes, and she was brain dead. So this was the situation. And we had done the first test of brain death testing, and it was all positive. We had done the apnea test, it was positive. Then the night team, my night team, two clever registrars called me saying that she's doing a movement. So this is the movement she does. So they said she's moving and she's breathing and she's moving. She's had this movement, right? So she had this movement. So what would you do now? Because she's a brain dead. She's already pronounced brain dead. Because I had checked her all brainstem reflexes, cornea, pupillary reflex, oculocephalic reflex, oculovestibular reflex, cough gag, everything was absent. Even apnea test we had done, it was negative. Then the night team calls and say this she has this movement. So, and this was the first apnea, and we did the second apnea. Second apnea also was positive. See what was more than 20, and she didn't have any breaths when we put on ventilator. And this problem was compounded by another thing, which obviously my trainees got intrigued, which I'll show you. So please understand, when someone is brain dead, there's a lot of involuntary movements that can happen. There can be twitching. that is not that will not exclude you from pronouncing someone, because these are spinally mediated reflexes. There can be twitching, there can be flexor spasm. So, and this, what she had possibly was a flexor of the trunk and the neck. So we call it as Lazarus sign, which is very clearly recognized entity in brain death patient. And this is something that happens. And what you saw possibly in her is a flexor spasm, which was spinally mediated reflex when she was disconnected from the ventilator. And they can have even movement of the hand, flexor, supination, and pronation can happen. And there is something called triple flexion. They can even fold the legs. So all these are spinally mediated reflex. And the sacrosanct thing is your clinical examination. If there is all the brainstem reflexes are lost and apnea test is positive, there's no reason to believe that we should not pronounce a brain death. So this is a very simple thing, but this is something which can confound a lot of decision making and lead to a lot of confusion, especially with the grieving families. And this was a different patient. We had a problem in a different time, but I'm just showing this as a continuum. And they can have flexor extension and passive displacement. So this was another case, not this patient. So similar patient, he was pronounced brain dead. And then our trainees see that she has this breaths. Okay, so this is quite intriguing, right? I mean, apnea test is positive, all brainstem reflexes, but she has this breaths on the ventilator. So what typically happens? There is an entity called auto triggering. So what this patient had was auto triggering, and you have to increase your trigger sensitivity. So obviously here the trigger sensitivity was kept low. So increase it to higher trigger sensitivity so that the cardiac oscillations are recognized as breaths and ventilator starts triggering. And this is what had happened. And once we increase the trigger to 4 from 1, and all her that ventilatory graphs that you see, which is auto triggering, stop. So basically, this goes to show the cardiac oscillations being recognized as a breath with a low trigger sensitivity is a well-known fact, and this is something every trainee should know. And you can see various situations. This can act as cause dysynchrony also. So trigger sensitivities have the concept of trigger sensitivity has to be understood, and this happened in our brain death patient, where cardiac oscillations were recognized. And the interesting way you recognize is obviously there will be absolutely no patient effort in the preceding breath. So if you see the preceding breath, there is no negative deflection, but that may be difficult to take. But interestingly, the ventilatory waveforms will be similar to the heart rate. So that is what is a giveaway. So if you look at the ventilatory waveforms, they'll be coinciding with your heart rate on the monitor. And if heart rate is high, even this breaths also will be high. So that is the way you can identify. So please bear this in mind when you are doing brain death, because these are the two cases which I saw in my unit. One is this Lazarus sign you saw, and this auto triggering reflecting as breaths on the ventilator. So this I thought were interesting cases. So the third case is the blue lady. So this was a 19-year-old female who came with consumption of 10 ml of compound. And so this is how she looked when she came. So she was hypoxemic. She had the blue face, blue hands, and she looked very blue. And you can see a right tube also having blue sort of a gastric secretions. And methemoglobin, that was a giveaway in co-oximetry. When we did, it was 65.5%. Lactate was 6.3. So what she had taken, which we realized was sodium nitrite poisoning. And friends, this sodium nitrite, very interestingly, she was a student of biotechnology or medical biotechnology, I think. So, and she had Googled about this particular poisoning, and this poison is becoming notoriously made popular by online websites as a suicide package. So it is called some dust. Sorry. So it's called some dust. So it is shown as sort of a suicide kit on the website, and she had looked into the website and she had found this and she had consumed this sodium nitrite with an intent. So be wary that this is becoming increasingly common and quite easily available. And she found this on a website as a means to end her life. And she had a previous suicidal history also. And why does this cause sort of a lethal problem and a life threatening? because sodium nitrite converts ferrous compound into ferric compound. And this ferric compound, because when it binds immediately to the hemoglobin, and this has inability to bind to the oxygen. So the ferric state in the hemoglobin has inability to bind to oxygen, and this leads to reduction in the oxygen delivery. It can bind very quickly to the hemoglobin, but it has inability to bind to the oxygen and help with the oxygen delivery. So oxygen delivery comes down, and this leads to increased lactate because of tissue hypoxemia that happens, and they'll have hypotension and severe metabolic acidosis, which all these features this patient had. So because there is reduced oxygen delivery, your microcirculation gets affected, tissue hypoxemia sets in, and she had all the features. She had hypotension, she had high lactate of 6.3, metabolic acidosis, and saturation will be normal, but obviously your PO2 will be very low because of the decrease in the oxygen delivery. So this was the case, and if you see, she underwent plasma exchange, and if you look at the discarded plasma, this was the color of the discarded plasma, which was like a chocolate brown sort of a color. Uh, so methemoglobinemia normally should be less than 1 to 2%. So if you have higher methemoglobinemia due to whatever consumption, so it produces various signs and symptoms. At 10 to 20%, it can cause cyanosis. 30 to 40%, it can cause headache, fatigue, tachycardia, weakness. So she had 60, more than 60% can cause lethargy, convulsions, coma. More than 70% is lethal. So this is the sort of a uh, clinical conundrum that they can end up with. Treatment is methylene blue. So the dosage we gave in this particular patient was 1 milligram per kg IV as a bolus over 5 minutes. And usually one dose is good enough, but in this, since it was a severe methemoglobinemia, we had to repeat after 1 hour 2 mg per kg. So this is the maximum because this is good enough as an antidote to circumvent the sodium nitrite sort of a poisoning, 2 mg per kg. Along with this, high dose vitamin C was given as an antioxidant, and she was subjected to plasma exchange. And along with this, so she was subjected to hyperbaric oxygen. So if you look into the whole literature, when you are giving methylene blue, you have to do the G6PD deficiency levels. So for her, it was done, it was normal. So plasma exchange is done as a desperate measure, and hyperbaric oxygen, you see a lot of case reports, but one of them should suffice. So plasma exchange is a better tool to sort of reduce the burden of sodium nitrate poisoning. And because she did become jittery and her cyanosis was not coming down, we had to subject her to hyperbaric oxygen at 280. One session was good enough. After all this, her methemoglobin level came down to 0.6%. Slowly, she got better. Cyanosis slowly sort of faded. Obviously, it would take some time. And clinically, she improved and she was discharged home after psychiatric consult. So, just a case in example to show as to how you have to explore other options in hastening the recovery. Like plasma exchange is something that you have to keep in mind. And these are the type of interesting poisonings that you will get, and you may have to be geared up to provide multimodal sort of a care to improve the outcome. So this was the third case. So the fourth case was a case of toxic epidermolysis necrosis, 36-year-old female who came with high-grade fever for 5 days, who had conjunctival suffusion. She had received antibiotics for 2 days, then developed skin rash after 1 day, and infective workup was negative. So basically, she was very unwell when she came in. She developed erythema, which moved to urticarial plaque, and then she developed bulle, then epidermal sloughing. Basically, she had severe form of Stevens-Johnson syndrome progressing to toxic epidermolysis necrosis. And this was a patient who had urticarial plaques and relative sparing of the trunk, and then this is all the epidermal sloughing. So just for our audience to delineate, you call it as Steven Johnson if the skin involvement is less than 10%. We call it as SJS bar 10 if it is 10 to 30. We call it as toxic epidermolysis necrosis if the involvement of the skin surface is more than 30%. So, and we published this case. So this was an older case which had come. So basically, 10 and SJS, it's a very rare condition, 1 to 2 per 10 lakh population. It's a medical emergency. It is fatal. The commonest inciting agents are antibiotics, NSAIDs, anti-epileptics, and chemotherapy drugs. So pathophysiology is basically there is a keratinocytes causes HLA expression, which leads to activation of the cytotoxic T cells, which leads to cytokines, which will affect them. So basically, there is an apoptosis of keratinocyte that happens following the HLA expression that it happens due to immune reaction. Cytotoxic T cells get activated, cytokine storm happens, and a lot of apoptosis of keratinocytes that are needed for the skin integrity are lost, and that leads to lot of epidermal integrity that gets lost. So the progression is erythema to the maculopapular rash to urticarial flap and epidermal sloughing. And these patients can have neutropenia with thrombocytopenia and they can go to MODS. So the principles of management is applying the principles of Burns because they would have lost a lot of the epidermal surface. So you have to put in the principles of Burns and have good infection control measures. But the topic for discussion is whether there's role of steroids because this is a patient who came with 10 and timely intervention with steroids and IVIG can save lives in this patient and prevent progression. So that is the key aspect that the audience need to know that early initiation of steroids at certain dose along with IVIG halts the progression of Steven Johnson is something that we have to look at. So the evidence is early steroids is shown to be beneficial, although one can say it is controversial. So the guidelines, if you look at the current guidelines, which has come from the Dermatological Society, they suggest prednisolone at 1 to 2 mg per kg per day within 72 hours and tapered over 7 to 10 days as a standard of care in toxic epidermolysis necrosis or dexamethasone 8 to 16 milligram. So whether there is evidence of pulse dose methyl. So in our patient, we gave methyl prednisolone pulse therapy. So the dosage that is to be given is 500 mg to 1 gram for 3 days. And the studies have shown that it reduces mortality to 0 to 7% and it reduces the cytokine storm. But now the question is, would you use only steroids? Because our patient had already received steroids. So whether you would combine the steroid with IVIG is a question. So for that, do we have evidence? So it is shown, these are the studies. Most studies have come from Japan and Taiwan. So steroids along with IVIG has shown to be synergistic and it reduces the mortality and it is shown to reduce the time to recovery as well. So the dose of IVIG is 0.4 to 0.75 grams per kg per day for 5 days, or it can be given at a very high dose of 1 gram per kg per day for 3 days. So this is the sort of acceptable regimes. In our patient, we gave IVIG and it is shown to reduce the mortality and reduce the time to recovery. And there was a network meta-analysis of 67 studies with 2079 patients, which showed that the combination of steroids with IVIG is beneficial. And there was a recent Cochrane review database in 2022, which has looked at etanercept, an interesting compound, twice a week, and has shown to have mortality benefit, which is a tumor necrosis factor 1 receptor inhibitor. And it is shown uh, reduction in time for the epithelialization of the skin to happen. And basically, etanercept acts as a TNF alpha, TNF1 receptor inhibitor and there are studies. So the meta-analysis of 9 studies by the Cochrane group in 308 patients showed reduced mortality benefit. Just for the audience to know that if you have 10, before our notion was it is just a good supportive care and treatment as burns, but now the current evidence signals towards early use of steroids, maybe perhaps methylprednisolone, pulse therapy along with IVIG. But IVIG is more expensive and etanercept, we looked into the cost. In India, it is available and it is much lesser priced at this point of time. So one could consider this also. Dose of etanercept is 25 to 50 mg, which is not very expensive. It costs around 6,000 rupees if you look into the price tag of this. So twice a week would not be very expensive. So this may be an alternative to think if IVIG is something that is not affordable by the patient. So that's a, so there was this another study where they compared steroids plus etanercept versus steroids plus IVIG versus steroid, and they showed the group with steroids plus etanercept had a better mortality reduction as compared to steroids with IVIG. This was a study published by the Taiwan group in 2022, and this was a study done in 242 patients. So this was the publication that we had done earlier. So the consensus is if you have a patient with 10, use early steroids along with IVIG. If cost is an issue, you could think of etanercept, which is not widely spoken about in our circle. So it is good for intensivists to consider this particular drug because there is some body of evidence pointing towards benefit. So this is a fifth case, a very interesting case. 42-year-old gentleman who's a neurosurgeon came with acute shortness of breath, feeling unwell since 3 to 4 days, and admitted to our ICU as actually possible COVID and ARDS. He was an NIV and HFNO, and this is the echo that was done on admission to ICU. If you see very carefully, he has had a vegetation at the aortic valve, so you can see there. So there is a vegetation sitting there at the aortic valve. So initially, the thought was it was a thrombus, but given his clinical scenario, the way we thought about endocarditis was he had a the cardiologist saw and he felt it may be a thrombus. But then when we clinically examined, he was hiding something. And what he was hiding is this. There was a non-healing wound in his leg, which was not actually clinically evident because he had always used to wear a socks, and this was not revealed to us. Once we saw this and blood culture came enterococcus faecalis, then we put all the things together and we knew it was infective endocarditis and there was a vegetation. So infective endocarditis, if you look epidemiologically, 31% is caused by strep pneumonia, 17, staphylococcus, 31% by staph, 17% by strep, and 11% by cons. And rest is by other organisms, and Enterococcus faecalis is one of them. So obviously, when you look at a case like this, we have to look at whether they fulfill criteria. So the key criteria is blood culture positivity. And for him, the two blood cultures came as Enterococcus faecalis. So two blood cultures positive 12 hours apart, along with having an echo evidence of vegetations, or three blood culture positive. If echo for some reason you are not able to identify, one has to resort to cardiac CT to identify whether there are vegetations. And if there are some organisms like Coxella burnetii, one has to look at antibody titers, and even one can look at the PET scan for the evidence of endocarditis. So these are the major criteria. Minor criteria is pre-existing valve problems or someone who has embolized, systemic embolization like splenic infarct. This patient had splenic infarct or mycotic aneurysm or strokes or conjunctival hemorrhage, or you have Janeway's lesions and you have a spondylolisthesis. So these are all the minor criteria, and temperature more than 38 degree. And other minor criteria is immunological phenomena like having glomerulonephritis, Osler's nodes, and blood culture positive and rheumatoid factor positive. So these are all the minor criteria. For diagnosis to be definitive, they should have two major and one minor, which is blood culture or echo evidence. So blood culture is mandatory along with echo or cardiac CT, or one major with three minor. So this gentleman had all the major criteria or five minor. The point in contention we are here to discuss is this is a gentleman who came with respiratory failure, needing HFNO, NIV, with a congestion in the lungs due to severe aortic regurgitation with aortic valve endocarditis, and who was extremely unwell with severe aortic regurgitation. So, would you intervene in the acute phase or in the subacute phase? That was the question, because here initially our cardiologist said, let him continue 4 to 6 weeks of antibiotics and then we'll subject him to surgery. Is that the right thing? The answer is no. If you look into the current guidelines, so the first phase is 2 weeks. Within 2 weeks, antibiotics obviously has to be initiated. In the first phase, it is combination antibiotics, which should be bactericidal, and surgery is an option. So this is the message I wanted to say. In the first 2 weeks, in an acute phase only, if there is a valve destruction with a regurgitant jet, surgery has to be considered. So this is the message I wanted to make in this case, because after 4 days of antibiotics, this patient went for aortic valve replacement. He came back extubated. He was very comfortable. I put in a PICC line and sent him home with antibiotics for 8 weeks. So this is a point in case where surgery has to be considered in acute phase, and remove the notion that you have to treat them completely for 4 to 6 weeks and then do aortic valve replacement. So second phase, the guidelines suggest is after 4 weeks, where you can continue IV antibiotics oral. This is to prevent relapse. So for native valve endocarditis, the regime is 4 weeks of antibiotics. For prosthetic valve, minimum of 6 weeks of antibiotics has to be considered. And this was the surgery of his destruction, the valve that was destroyed, which I got it from the cardiac surgeons. So basically, this is the case in example to emphasize that if you have, see, that is the valve that they took out, endocard destroyed valve. The valve was completely destroyed, and they had to put in a prosthetic valve for this patient. So that was the valve that came out. See, you can see that is completely destroyed. So, so please remember, you can save a life. So this life was saved. We did not wait and continue his sort of NIV, HFNO, and him being unstable. So the immediate plan to do a surgery within 4 days was the way out to get him better. Had we delayed, he would have landed up in more problem and more life-threatening sort of a situation. So even the guidelines suggest within 2 weeks, surgery can be contemplated upon. So this is the last case. So I'll just run quickly. We're running short of time. 47-year-old patient who is a chef in a hotel came with so he's a diabetic with HbA1c of 14, obviously not well controlled. He's had a previous history of acute severe pancreatitis 5 to 6 years back, underwent gastrojejunostomy and hepatojejunostomy. So came basically with septic shock. So he was admitted in another hospital, got worse. So 48 hours later, they shifted him. He was hypotensive at ER. When he came to our ER, blood pressure was not recordable and he went into VT arrest. So twice reverted, airway breathing circulation secured, resuscitated, ventilated. This was the initial ABG when he came to ICU. pH was 7.9, lactate of 9, and he was very sick. Basically, septic shock, treated outside, not gotten better, came to us, severe septic shock. So investigations, you see, he has a relative anemia, high counts, platelets was low, he has liver enzymes which were elevated, bilirubin was marginally high, he had acute kidney injury, CRP was 19, proccal. So obviously it is a septic shock, uh, treated outside with the previous pancreatitis. So source was not addressed. So that is the gist of this particular, how we have to look for the source. Tropical core was negative, HLH workup, because we were lost because we were trying to wonder where his source of sepsis was. ECG showed left anterior hemiblock, echo showed some myocardial dysfunction. So the point in contention is ultrasound was done. When he came, we showed hepatomegaly with fatty liver, with minimal ascites. So nothing spectacular in ultrasound. He was on dialysis because he was very sick, lactate 9, AKI, and he was resuscitated well by our expert ICU team, and he sort of stabilized. So what would you do now? So then his blood culture comes as E. coli, carbapenem resistant E. coli was his blood culture. So would you stop at this and just give ceftazidime, avibactam, astronam, just wait, or would you do something? This is a question I would ask the audience. Any other investigation? So we haven't got a source. Previous pancreatitis, he had a jejunostomy. When he's a chef, gone, became very sick. So so friends, the point in contention is that you have to keep searching for the source because ultrasound being normal, would I sit quiet? So we made a conscious call that we need to further investigation. Because he had a severe previous pancreatitis, had surgery, we subjected him to CT abdomen. And look what CT abdomen showed. So CT abdomen showed a huge abscess sitting in the liver, friends. So he, being a chef and handling sort of a type of profession he handles with the previous history, HbA1c, he had developed a huge liver abscess. So that's an abscess, friends. You look at the abscess. So with the fluid level, sorry, I'll show you again. So you can see very carefully that abscess. See that? That's an abscess with a nice air fluid level. So basically that was the source. Because he had a previous surgery and there was some breach in his gut mucosal barrier. So the point to be made is if someone comes so severely septic shock, you cannot rest until you have an answer where is the source coming. Either it should be urine or lung, somewhere it should come from. So we didn't stop with ultrasound. So ultrasound may not be the best tool to always have a confirmatory answer on possible source. So CT was done. We showed this. Pigtail was put in. He nicely improved and he went home. So, and even if you look at the guidelines, surviving sepsis, source control has to be attained within 12 hours. This patient had waited for more than 48 to 72 hours in another hospital. And that is strong recommendation. And even the interventions one embark upon should be a minimally invasive intervention, has to be done, and which is pigtail, which was done with the least physiological upset. So any source, it can be even a CVC line sitting, that has to be removed. So that is about the sixth case where the emphasis and importance of source control has to be put in place. So those are the six bouquet of cases which I thought was of different dimensions in ICU that we saw, which was of interest. So hopefully it was useful. So thank you, friends. So request you all to submit your valuable work with Journal of Acute Care and visit my website. So we have to discuss it. Thank you. Thank you very much.